very much for that kind introduction. Way too kind. And also potentially using up my minutes, which I'm concerned about. But you're too generous, and I'm embarrassed. But I'm absolutely delighted to be here. It's been a fabulous 2 days for me as I joined the working group yesterday, and I'd like to extend my thanks to Will, to Coral, to the organisers and to the funders, because it's been a wonderful opportunity to come out of WHO, a big white building on a hill, going through a little crisis, as you may be reading on the newspapers, to come and join and just get back into the passionate area of science, translation, innovation, technologies. And here today from so many of you, and I congratulate all the speakers and those particularly in the session beforehand. So I don't know what I did to get this time slot, but I'm between you, the Ken Rothman Award, and the end of the day. But I'm delighted there's so many of you still here. So I'm going to thank you as well for still being here. And I looked up on Google for some, or AI for some advice, just like you did, Will. And of course they gave not the housekeeping, but unfortunately I have done the opposite. I've doubled the slides and halved the font. So you think that's a joke? It may not be. So we're going to move into something with that kind introduction around population health. And I'm going to start with a problem. And my problem that I'm bringing to you, and I hope like many of the speakers and the whole ethos behind this network, is to collaborate across industry, across sectors and disciplines of science, and of course the community and engagement. And so what is my problem that I'm bringing to you at 4:48 on this Friday the 13th, to be marked down in a note of time? It is that we're trying to measure physical activity in the population, and population health and public health. And it sounds so simple, and yet many in this room know it actually is so difficult. And many of you are contributing to finding our way through this. But here's a population, and a simple question that every public health department of government needs to know is, how active is their community? You'll see why we've got this problem and why it's so important. And I'm going to bring it to you because guess what? I think you could be part of the solution, and the work we're doing together could help us. So where did this problem come from? Well, first of all, I wanted to cover, why has WHO got this problem? So very quickly on the screen, you can see the functions of WHO, and it serves all countries, as you're frequently hearing, but monitor and assess trends in green, second dot point, because it underpins the work. Understanding the diseases, where they are distributionally, geographically, and understanding the causes is fundamental to what we're going to do across the continuum of care, from prevention through to treatment and care. We also set norms and standards. Well, that's interesting when we put those two things together when we move into the work we're going to be talking about. And we like to contribute to shape research, and that happens more or less depending on the areas. And I argue it's vital at this stage. And I hope some of this presentation, the discussions I've had with many of you, might be shaping your thinking. And I certainly do hope maybe there'll be some take-homes from this presentation to you. I wanted to put in what is population surveillance, because I'm going to be talking about that a lot. And I know we've got a diverse field here. It may not be common language. It could be called population monitoring, the surveillance triggering that sort of negative but also communicable diseases. And yes, that's included. But you've already read the slide. It's the ongoing systematic collection and analysis of interpretable data, to which we can use those then to inform and actions to improve population health. It monitors the diseases, but also the risk factors and their determinants. It provides estimates to know what's going on in ways that are meaningful and reference to other guidelines or metrics of importance. And it's over time. And that starts to bring in the quality of consistency consistency and systematic that we need if we're going to track trends over time. Core public health function. What does that mean what does it look like? Many of you have been talking and presenting very interestingly on some clinical care and clinical contexts. Then some of you work with groups. Many of you in here are working with cohort groups over time, still with the same measurement challenges. What population surveillance does is take that picture of the national population, not one, but takes a representative sample and asks and follows that, or doesn't follow, rather asks and gets measurements from that sample. Representativeness is critical. And This is what we're going to focus on. WHO wants all countries to do it, and it would like all countries to have some level of usable comparability. We might like to compare and track trends in tobacco use in different countries to be informed about the influence of industries' activities or the success of interventions and policies like tax and regulation. If we have different data in every country on all the things we measure, it's a mess. I don't think that's quite where we are, but we would like more consistency, and certainly the area of physical activity is challenged. So what are we trying to actually measure in population surveillance on physical activity? Well, it's guided by the policies you were introduced to that now are around for the Global Action Plan on Physical Activity, set out to deliver and guide countries on implementing the policies that will change and promote health through physical activity. A target was set. The wording of the target leads to the metric. The metric is what we want to measure. So those of you who can see it, the target is a 15% reduction in physical inactivity by 2030. Given this group, it's more precisely the relative reduction, which I read out, in insufficient physical activity as defined by our guidelines. We do know what we want to measure, and that's a good thing. We're not out on a fishing trip. We actually need to measure and report by 2030. By the way, we missed the 2025 target. We did not make 10% improvement. Where does that metric come from then? The guidelines and all of the epidemiology. There's many in this room that have contributed to it, which can put many different things on this y-axis, and the graph will broadly be the same. There's benefits from being more active. More is better. Standing up and moving is better than sitting down for too long, a certainly extended period of times. And somewhere, there is a line that's been drawn by the best and the brightest in the world to say that's about where we really want to get the population to. More is better, but that is where we can call a benefit to population health. We don't have a continuous measure yet, so it was drawn at this point, and therefore those other messages are still there, but that is the metric that we try and focus our measurement on and our guidelines. Behind that is the evidence that unpacks different types of physical activity and different amounts for different populations, and all of this is accessible from the WHO website. Therefore, we can look at this slide and say if that was where that line was on the graph and it was pointing to 150 minutes to 300 minutes, this is the metric we're trying to measure. We also, in the latest guideline, have a very keen focus on reducing the sedentary time following emerging epidemiological evidence on the risks there. We're not measuring to date the middle bit, largely because we don't have the tool, nor do we measure at the top or the strength training, largely because we don't have the tools. So you can now see, and going forward in the presentation, the green and the red are the metrics we're trying to measure, and that's what we'll go on. What do we measure it with currently? Well, current measures, the questionnaire. The questionnaire that many of you maybe still currently use. It's been around. It's been our tool, in fact, our tool of choice, because if you wanted to measure physical activity until the development of the technologies that we're all sharing. But we can see on the right-hand side some of the well-published and well-known limitations. Have you ever, oops, I'm sorry, let's have a look what happened to the extra bits there. Fortunately for you, we're going to spare ourselves reading this entire questionnaire to get you to remember last week and to define vigorous and moderate. And by the time then we ask you, were you active at work? And if you said yes, you get 2 more questions. How much and how many days? And then we'll go on to the next bank of questions. You get the idea? Long, repetitive, takes a lot of time, and still relies on people remembering what they did last week in minutes. The trouble is that there's more data that is, just checking whether I've got the right slide deck there, but anyway, I'll roll with it because that's, the order is a bit out of date, but anyway. The trouble is, new evidence is changing what we've got and the information and changing what we want to measure. And I'm showing you here something just weeks old from Ulf Eklund and his team that showed us that even smaller amounts of physical activity, in contrast to the graph I showed earlier from WHO, in contrast, it's showing small amounts can have substantial gains. Gains that when put into the population doing 5 minutes more, 10 minutes more, could be profound in the population's health gain. pressures on the NHS reduced, cost, care and services reduced and savings made. Whether it's the health or the economic or the crisis in the NHS burdens that you want to talk about, this is profound in showing us that physical activity in different amounts is important. New evidence which is pointing to where guidelines may go in the future. There are many people, this is the wrong slide deck. It didn't replace the first slide deck, but that's okay. It's going to be a bit disappointing at the end unless some really fancy work can happen and you can catch me up. But anyway, I'll give you that challenge back there. We have got a lot of people who've been saying we've got to change. We can do better. We can do better than the self-report. And you know why, because you're all here at a conference and you're all working in this area. And so when we look at, maybe you're doing exactly what I said, changing. I'm not sure whether you are. Anyone going to tell me? He's actually changing it. So what I will show you when the new slide comes up is how important it is that we're here. Someone yesterday said, well, what's the point of going to wearables? Is it just more data and this research community wanting to have better data, more data? What difference will it make? Well, I've shown one example with Ulf Eklund. That self-report questionnaire cannot measure 5 minutes. It poorly, but at the moment, best we've got, measures the total amount last week. Minute amounts of 5 and 10 minutes are poorly recalled. Thank you very much. Appreciate that very much. So we'll just pick up a story, which was that with that self-report, what's the current level of global physical activity? Answer on the wall. Currently, 31% of the adult population globally do not meet that recommendation I showed in the red line and we need to measure and are using self-report. 1.8 billion people join the problem we have to motivate, encourage, engage people to be more active for all the health benefits. What does that look like in data? Very quickly, you see in the top the global data, and in green, light green, you'll see 2010, and a slight worsening by 2022, going the wrong direction. I draw attention that we're looking at inactivity. Numbers going up is a bad sign. So you can see also from here the disaggregation by regions. These are regions of cultural and economic groupings. It's of interest to see that there's variation. Sub-Saharan Africa has got lower levels of inactivity. Middle East has got much higher. When you break that out by gender, you see considerable differences. Indeed, when we break it out by gender, we have male in the red, female in the blue, every country's data, and now we are looking at trend. Trend shown in the average of the region being shown in the darkest line, but look at the differences of every line. Dan, I hope you're enjoying this. This slide's for you. And you can see it's a busy picture. Some regions are going up, bad news. Some regions are going down, better. Some regions are horizontal, not too many in this picture. We also looked forward for the first time, modeled those data, self-report, to look forward. We're off track. I now add a third bar, and you can see in almost all regions, the red bar showing you that by 2030, estimated, whatever we're doing now is not enough to change the levels of population physical activity. So we've got a large challenge. It's a measurement one, but it's also in the implementation of policies and actions. Thank you for going back. This is the last one of slides to show you, of data, to show you that an interesting point is the pattern of the hockey stick increase at age 60 in almost all of those sub-regions that we've got in both male and female, sharper in some regions than others. So an aging population, the demographics of the world, and typically, and shown here, is an increase in physical activity at the age of 60. Sorry, we now have to quickly, I'm going to spare you that. There's that problem. Can we do better? And we need to, because my favorite slide, and thank you very much at the back for catching up. I wanted to insert this because this is showing you a real problem we should worry about. On the left here, we have the dose-response relationship with cardiovascular outcome using a questionnaire. It's a pattern we've seen. If you're more active, you have greater risk. broadly just look at the shape of that pattern. I know you can't see the x-axis terribly clearly. What I wanted to contrast it with is what would happen and what we're seeing when we move to a wearable. Look at the right-hand side. Now you're seeing data coming out from a wearable, published by colleagues Manos and his team down in, and using the UK Biobank data, so there are many in this room with that, and we start to see a much sharper, and I apologise because this is an imperfect comparison, but you start to see a sharper and higher risk reduction. In other words, when we start measuring with wearables, we're seeing different patterns, different magnitude of association, and starting to show us we are underestimating the importance of physical activity with our self-report measures. If you need a cause or a use case for why we should be looking at wearables, we'll learn a lot more, and it might be very important from wearables. If you need a second use case of why we need to shift, look at these data shared with me from Norway. Their national population data using a self-report says nearly 70% are active. Their wearable data says it's 50. That's a 20 percentage point difference. We are overestimating physical activity. Put the two together. We are underestimating the gain. We are overestimating the level. We therefore are grossly underestimating the magnitude and impact of both the gain that could be had from physical activity, but certainly the public health problem that we face. So with that, I'm going to skip that, and I'll skip that, because we're back to where we are with Ulf's latest data, a third reason with new evidence coming through that wearables are needed. And I'll skip that to get to here, to now say, we know that, many know that, and I'm absolutely delighted that the funders who are in the room, the researchers that are across different disciplines are all coming together to say, can we measure physical activity well with a wearable? How many countries are trying to do this now? Well, of 194, 12. That's a reasonably good estimate. One country did it over 15 years ago. Okay, let's call it 13. And one country uses a pedometer, not an actual accelerometer. It's about 12. There's a long way to go. And so what the challenge is for us is, after this conference and the work that you're all doing, we've had technological advancement that hasn't translated into practice in this area yet. And I know your presentations have been about a range of other areas and work we've got to do. But in this area of population health, with those data I just presented, we need to get going. And we have a challenge to cross that bridge with the technologies and developments and science to get it into the practice and field of population surveillance. I think it's doable. I think there is a future when more countries have wearable data at population scale, many more, and perhaps estimates will be based on wearable, and guidelines will be based on wearable. That future, I believe, is in sight. But it's a long way. That's the best I could do on a Friday. It's a long journey, not a short bridge. So what WHO has set itself is, can we help this field? Can we be round the table? Can we set a path? Can we invite others? Can we join with others to say, can we get the guidance to help the other 170 countries that are not even trying to use wearables to put them into their population systems that typically happen every 2 to 5 years, depending on each country? It's part of a health check that's done, involves other measures, but they're still using that questionnaire. Can we substitute or complement in ways that we understand and are beneficial? We've had 4 meetings. And my task is to tell you about them, to excite you, and to invite you on the journey that is now unfolding with several of you in the room already, and I hope many more after it. These 4 meetings have been a process of looking at the problems to get across that bridge. Where are we now? Where do we need to get to? And what are the issues we have to deal with? So, the first 2 meetings, adults and then adolescents, had to reflect on the strengths and weaknesses of the self-report, look at the feasibility in a broad sense of wearables, and with the people who matter in the room, and that's a political and tactical aspect, get agreement that we should actually stop investing in changing the question wording and start investing in looking at wearables. This was achieved with both age groups. But the problems kept coming up. But what device? But what analytics? But it costs too much. Have you heard those before? Have you heard those criticisms before? Yeah. So we met for a third time to say, let's get down to this. What is the device that's needed, or the device specifications? What are the characteristics? What are the protocols? You're doing 3 days, you do 4 days. You require a weekend and you do 12 hours, but you do 24 hours. Oh, that's just that one. Okay, you've got the hip, you've got the ring, as you happen to be sitting there. You've got the ring, you've got the, what are we looking for? Hip, thigh, and wrist, of course. This was our meeting, kindly held in Canada, to look at, well, let's narrow down to the must measure, because we can't talk about everything, and that was a lesson learned. Let's look at the device specifications as illustrated, and let's also look at a couple of issues around the algorithms. What have we got? Where are we? And do they apply to everyone? A comment made earlier at the start of today. And we asked that particularly around older adults and people with diverse movement abilities. The 3 metrics we narrowed the conversation down to were the MVPA I've just shown you, that line, and of course, steps, because it's possible and it's likely to be a very useful tool and a very useful metric. Sedentary, I showed you. We then looked at device specifications. So when you have 20 people in a room for 3 days, you fill out spreadsheets, you argue, and you try and reach conclusions and agreement as draft for further consultation on all the issues like wear location, wear time, number of axes, resolution, sensitivity, noise floor, memory capacity, waterproof, obvious, but not always there. Are you giving feedback to the user or not? 20 to 25 different characteristics. Some of them are functional inside the black box, and some of them start to move into how you use it and data processing. The red boxes show you where we did not reach agreement in that first meeting. And I thank everyone who was there, because it started to put the problems or the issues into a way we could start to solve. So we had a second meeting to carry on, because there was red boxes we hadn't filled, and we learnt from the experiences in the room, there was still so much diversity, we needed to meet again and nut it out. So a 4th meeting was held only in November, so just before Christmas. I'm writing up the final report at the copy editors this week, and will be available to you. And we set a challenge to look at where we didn't finish at the Montreal, those red boxes of wearables, and listen to the end user. In the theme of the conference today, listening to those involved, it's Ministry of Health, surveillance teams, statistical teams, data teams who say, you want us to change what we've been doing and got 20, 25 years of data, as in Canada, and take up this idea? You've got to be kidding. Apart from Canada's done it. So they told us, how do you change a Canadian system? So they've got 7 waves of data using wearables, first on the hip and they changed the wrist. How did you change the wear location? What happened to your trend and your tracking through that period? We also heard from others who countered with their experiences. As a result of that meeting, and I'm going to go on to tell you the 5 or 6 things that are happening now, one of them is that WHO has found a mechanism that we're putting on the table as a way to help this field. Despite the guidelines I've mentioned, the policies we've mentioned, WHO has a stream of work which is defining technical product profiles. It's if you have a public health problem that needs a technical solution, and there isn't an obvious one, and you need to consult, and you need to come up with a minimum standards, or recommendations, or regulation, choose the word you would like, or discuss all options, we can and are looking at this process to bring all of this together, and it's a cycle from the problem through to the end user of preparing a guidance tool on how, I'm known for choosing a country, it's merely random, I'm going to choose Bangladesh. How will Bangladesh start collecting wearable data in their next round of population surveillance? In addition, we have to look at the tools we could use. the products that are available. We've called them all day. We've been calling them the consumers or the research. They are all doing the purpose or purport to do the purpose. And we are doing what's known as a landscape analysis, using and looking what's out there, and many of it will exceed our minimum specifications as written at the moment. Others may not. To do this, we've drawn on the Wearable Landscape Network that I wanted to introduce to you and give a shout out to them if you haven't heard about them, with their website. This is a group based in Europe but globally who are collecting all the evaluation data on every device, critiquing, and it's an open source online searchable database on every device that's available that they have got to, and it's extensive. We've asked them to complete a landscape analysis with a cross-reference to which devices will meet the specifications at this time, for a discussion about whether there is an existing product and future products may wish to be guided by this process. That was weird to have the meeting objectives there, and also the photo, because the Dutch had a particular interest in cycling. So on this Friday evening, how about being challenged by the Dutch government about which device measures cycling best? If we had time, we'd have a poll, and many of you would stand when I said thigh. Yes? But then you'd say, thigh? Are we really going to be using a thigh-based instrument? How feasible is it? The cost of these? Well, can we use a wrist? And what about any other location on the body? Which body location, which device? Well, that's why we're all on bicycles. And we're in the Netherlands, of course, enjoying that opportunity. So from that cycling discussion, which was left with some encouraging signs, particularly about the different devices and different wear locations, particularly about the opportunities to harmonize data, and particularly by some new analysis that were done for the meeting by groups like Aidan and his colleagues here with Biobank and other groups who could access some data. They asked the question, can cycling be detected accurately and sufficiently for a population health measure? It remains unanswered because they were doing rapid analysis. What I'd like to summarize, though, is the main learning we got from countries sharing what they do. And there's those of you in this room who know this story well. Every country was doing it slightly different. So we learned there is no one way at the moment. Not only was the device different, the algorithms they used were different, the wear time was different, on all of those variables I've mentioned were different. And so we've ended up asking ourselves, whilst the methods are different, which one and how will we narrow down to say what is the guidance for our Bangladesh country of example this evening? In addition, we found that countries use the wearable in different ways. I started thinking it was an obvious use that you would replace the questionnaire with the wearable. To my surprise, there were countries saying, no, we're going to keep that one, but we want to understand the behavior and the patterns and the distribution. We want to use the wearable to inform us on policy and insights. We are not changing our trend data. Two very different uses. One gets rid of the questionnaire and one retains the questionnaire. So it's rather interesting to learn that there was this conversation going on in 10 European countries who are all quite similar, let alone going globally yet. So we're left with an open question for further discussion about those different models of use and what's useful for what purpose and what policy agenda. A second profound common element was representativeness. And representativeness was the key issue that challenges using wearables in population samples. It's the same as the cohort discussion. We are not getting certain groups, and we need to do better at getting those groups to be involved if you're going to ask them to wear the wearable, particularly when it's for 7 days, and particularly when you have to go and get it from them. It is a feasibility problem rather than a technical problem. But that's our problem when we're trying to do population surveillance. I'm going to skip some of these, but I've already alluded to the differences, and I do apologize for some slip up here with the slides getting out of order. The second thing and I know you're all interested in this, what was our final discussion about all those different and holding position on all those issues about standardization? Some of us in the room thought it was all about device. No. Others, and it remains, Where location is critical. You get a different result from a different where location unless you have used the same raw data, and use the same data processing pipeline and algorithms. And if they're different locations, they are a harmonization. This became the critical issue. So that was a shift, and it's informing WHO what it needs to do. I'm very conscious of time. So what next? What next? We're going to follow that plan. That is literally my handwritten notes following the meeting of November 25th, saying we have got 4 streams of work. There's more research to do, which we're inviting everyone and anyone to get involved in to answer the questions which I've alluded to in this talk. We must continue with the guidance as a reference point. It will be discussed, it will be consulted, and people probably contested, but it provides a line that we can start following. We need to get in the field and try. And the theory and the principle very comfortably adopted was test, adapt, and try, rather than waiting for perfection. And finally, we need to do a lot of comms, because Bangladesh and many of those other 150, 60 countries will be saying, why now, and how do I do it? And we have not got the answer to that. And we also don't have sufficient resources to make all of that happen concurrently. There is research underway, and I want to have a shout out to people who are doing research, self-formed and active, to address the issue of independent validation of algorithms. A recurrent theme in the meeting was that it is researchers publishing their own research and their own algorithm. There's no independence. There's industry publishing their own, but there's no independence. So can we have a system? And this is a piece of work I'd be happy to tell you more about. They will be following models like this from Sarah Keedle and the appropriate area, and that's what we haven't got enough of: real world and efficacy trials of the independent sampling of the independent samples of testing the algorithm. ProPass is helping, as many here, with algorithm and harmonization. How will we use if their countries choose a different device and a different where location? Solutions are coming. And we need to basically come back to that primary question, which is, are we looking at the way forward to get from the knowledge and science and technology being used in research to getting it across that bridge to being used in countries? It's not a 1 year, but I think we can make progress in 1 year, and I'm certain we can make progress over the next 2 to 3 years. And I'd like to see us make progress by 2030, when we can update the guidelines, update the measurement tool with guidance on how to measure and how to use a wearable. So I'd like to finish with the invitation that in different ways, the research you're doing has got value to helping. And I'd be happy to talk with anyone who'd like to hear more about those groups that are going and more about the work going on. Thank you very much.